Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm the digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
Today we have a set of 6 questions on ACO quality reporting from Jason, so let's just jump in and get started. So first today, Dr. Mingle, Jason says, "It appears to me that the grading system for ACOs is primarily based on their reporting rather than the actual health outcomes of their patients."
Yes, thanks, Kyle, and thanks, Jason. I'll point out that all of today's questions came from Jason. I think he's pursuing a master's level understanding in ACOs and quality reporting. You've made an astute observation, Jason. You're cutting right to the core of the complexity and confusion that is quality measurement. I'd argue with your characterization, ACO quality measurement primarily measures an organization's reporting aptitude. I think they're both in there, real quality and the aptitude. I think you may be spot on for early, immature, and undeveloped measurement systems. But with time, development, and practice, the actual quality of the outcomes eventually shines through. I'm not aware of any measurement system that purely measures what it intends to measure. The first hurdle to cross in any measurement system is to develop and implement an effective measurement tool or system. Until that system is uniformly effective, the comparison of measures typically first compares the effectiveness of the system, and then later, as you refine that system and get good at it, it more thoroughly measures and compares the actual outcome. So of necessity, before they can effectively measure the targeted health outcomes, they have to measure a cascade of factors that have to exist before the desired health outcome is the primary output. Well, I wonder if I lost you somewhere in that chain. To try to make this simple, there are 10 factors, I think, that collectively make a good health outcome measurement. Only 2 of those 10 factors actually represent great care, but failure of any one of them or combination will result in a bad score. So the first 2 factors are to recognize and document eligibility of the patient for the care. The second 2 are to provide and to document the provision of that care. That's actually a care-related piece of this. Next, for 5 and 6, measure and document the results or the outcome. You can provide great care, but if you're not actually measuring the results, aware of the outcome, it's hard to report on your outcomes. Then it's to identify the denominators. So you have to be able, if you've recorded, documented it well, and you have a good identification system or measurement system, you need to then identify the denominators, that is the patients or visits that are eligible for measure. Then you identify or recover the outcome, the numerator status, and patients representing, that is the patients representing successful performance. And then calculate the performance measure, that's 9, and 10, report the metrics to those interested in it, in this case, a CMS. In any one system, improvements in qualities filter through to the results, but the absolute value of the results and the cross-organizational comparisons still reflect a fair amount of the differences in all of the other measurement and reporting effectiveness measures. So it really is a complex system. You can fail on the system itself or the measurement itself, but as you get better at that, then your comparisons are going to be on true performance. So it takes some work, takes some time, takes some practice, takes repetition, takes a little bit of knowledge and devotion to get this all working well. Thanks, Jason. Good question.
So Jason's next question for you, Dr. Mingle. I'm curious about the specific quality standards used for these measurements. Are there defined benchmarks for metrics like A1C levels and blood pressure, such as A1C less than 6.5 and blood pressure less than 120/80? Or are the quality standards based on something else entirely?
Another great question, Jason. You've introduced three terms or concepts in your questions. Those terms: one, standards; two, benchmarks; and three, quality standard. Medicare may use these differently regarding quality measurement than they may be used elsewhere or by others. So I'll define each of these three terms relative to Medicare quality reporting. So standards, the term standards, refers to the physiologic number and what it means. It implies a set of agreed upon numbers that represents outcomes. There's measurement, research, judgment, and argument involved in setting these standards, and they're generally set by some kinds of standards, trusted standard setting organization. There are standards for labeling hemoglobin A1C as normal, diabetes in control, diabetes in poor control, or diabetes out of control. Standards, according to the Center for Disease Control: 5.7 is normal, 5.7 to 6.5 is considered pre-diabetic, above 6.5 is diabetes, up to 7 is good control, 9 or above is poor control. A similar scale is applied to systolic and diastolic blood pressures. Each pressure, systolic and diastolic, have standards, differs a bit by the standard setting group, but there are levels that are considered normal, elevated, hypertension, controlled hypertension, and malignant hypertension. Quality measurement could involve establishing the average physiologic measurement across your practice, such as the average blood pressure in my hypertensive patients is 144/86, or the average hemoglobin A1C in my diabetic patients is 8.9, but that's not how it's done in Medicare's quality reporting. Medicare chooses to have us count the patients above or below those certain standard levels. For hypertension, Medicare wants a count of hypertensive patients with blood pressure under 140 systolic and 90 diastolic. They're asking you to calculate what percentage of your hypertensive patients are in good control. This is typical of most measures where higher numbers mean better performance. For diabetes, Medicare wants a count of diabetic patients with a hemoglobin A1C above 9. They are asking essentially how many of your diabetic patients are poorly controlled. It's called an inverse measure, where higher numbers mean worse performance. Now, benchmarks, when used by Medicare in regards to quality measurement, benchmarks describe how your performance rate compares with your peers. It's Medicare's standard for turning your performance rate into a quality score. Benchmarks gives the accurate measurement meaning in context. So if I'm using a yardstick to measure a piece of string or a board, knowing that what I want is let's say a 12-inch measurement, that's my standard for this production. Now I can use that yardstick and put a mark on my bench, and so I can lay the board against those marks and say, well, this one hits the standard, it's my benchmark, and I don't have to convert it to a number and say it's 12 inches or 16 or whatever. So that's essentially the meaning of benchmarks: to step away from the direct number that you're measured and give it direct meaning by comparing it to that standard mark. The quality standard is the specific name of the benchmark that Medicare is using to trigger payment of shared savings or moderation of shared losses. So there is a relationship between the standards, benchmarks, and quality standards, but there are sometimes subtle gradations of meaning. To review, standards in the context of medical quality reporting refers to the translation of science and research onto a scale that uses these measures to predict the health outcomes. Benchmarks relative to CMS quality reporting are the translation of those clinical standard measurements into a standard language that compares effectiveness of the practice. So it can relate a hemoglobin A1C control to a blood pressure control and all of the other measurements that Medicare supports. And the quality standard is specific benchmark Medicare has set that above which shared savings are fully shared or shared losses are ameliorated. So I may have just made it more confusing. I hope not. I hope this makes it easier. Thanks, Jason, for the great question.
Jason goes on to ask, I'd like to understand how quality performance is graded and determined within ACOs. Is it a straightforward calculation based on the reported data, or are there additional factors taken into consideration? Additionally, it's intriguing that there is a small built-in bonus for improving quality over the prior year. Could you provide more details on how this bonus is calculated and awarded?
Wow, great question, Jason. Let's see if I can lose you in this one. The first challenge of the ACOs is to collect raw data from all the practices. And that's data that identifies the denominator, that is the patients or visits eligible for each measure, and then the data that defines the numerator, which is the outcome or intermediate outcome of interest, and is usually clinical in its source. And then once you have the raw data, you need to deduplicate and aggregate patients. So when the patient is seen in multiple practices, you have one measurement. You're looking at the latest or whatever the specifications require for which of the multiple measurements is used to set the numerator. And then once you have that done, calculate the quality performance metrics and submit it to Medicare. Now, there is an improvement bonus, as you've mentioned. Medicare calculates and adds, if earned, a quality improvement score. The requirements of that quality improvement score includes this year's submission has to be complete. It has to have all measures that are required to report. In the case of ACOs, it's the APP, so it's for 2023, it's and 2024, it's the 3 APP measures or the 10 web interface measures. There has to be a score from the prior year. So if you didn't submit for any reason the prior year, you can't be eligible for an improvement score this year. The aggregate quality score this year is then compared to the aggregate quality score last year. It's not on an individual measure basis. It's on that aggregate quality score. And therefore, it can actually compare the web interface measure set against the ECQMs or MIPS CQMs or any combination thereof. It's calculated as a ratio of the difference in scores divided by last year's score, and then that result is multiplied by 10% for a maximum 10% improvement score. Now, only improvement goes into the calculation. If your score dropped and you actually deprecate over those 2 years, that doesn't penalize your score. You only get an improvement score if you actually improve. And it can't drive your total quality score above 100. If you're already running a perfect score or near perfect, that the addition of that quality performance score can't pull you above 100 for the category. Now, there's also, for ACOs, it doesn't happen in MIPS, but it happens in ACOs, there's a health equity adjusted quality performance score. So there's a health equity adjustment that's added to your quality performance score. It's up to 10 points, again, capped at 100, so you can't get above a perfect score. The bonus points are defined by a measure performance scalar multiplied by an underserved multiplier. The underserved multiplier counts the number of patients who are likely to be in an underserved group. And the measure performance scalar compares or groups practices into 3 performance levels: the upper third of performance, the middle third of performance, and the lowest third of performance. Those who are in the third of the upper get 4 extra, that multiplier is 4. Those who are in the middle group get a multiplier of 2, and those in neither of those groups in the lowest third don't get don't get a multiplier. It's 0, so it renders that a 0 bonus. The underserved multiplier relates to what's called an area deprivation index. And there is Medicare tracks, and it's available on the web, a zip code specific area deprivation index that ranges between 1 and 0. So looking at the census related factors in each of those regions, they set this deprivation index. So your underserved multiplier is defined as a proportion of your assigned beneficiaries that are in an area with a area deprivation index greater than or equal to 85. So this is just looking at the address of each individual and comparing it to that national table of area deprivation indexes. And then just counting those that are in an area over 85 and using that in the calculation. Or they also look and use alternately, whichever is a bigger number, the proportion of beneficiaries you care for who are either duly eligible for Medicare and Medicaid or Part D low income subsidy. And if your multiplier is less than 20%, so less than 20% of your patients are in those uh, areas with an index of 85 or greater, you don't get any health equity bonus points. And to get those points, you have to submit all three measures, meet case minimums and data completeness, meet the quality standard. And this is not applied to the web interface reporting as an incentive to get people moving into the CQMs of the APP. This is only given to those who are using the CQMs. So yes, you're right. There's a very specific calculation that gets to the quality performance score, and then two adjustments, that improvement bonus and that health equity adjusted quality performance score. So thanks, Jason. I hope this helps.
Great question, Jason. So Jason's next question for you, Dr. Mingle, is, are ACOs obligated to demonstrate year-over-year improvement on the three specified measures: diabetes, HbA1c and poor control, preventive care and screening for depression, and controlling high blood pressure?
There's no overt obligation to improve your score year over year. Basically, if you achieve a winning score, you collect all of your shared savings. But an expectation of improvement is built into the process. Grading is on a sliding scale based on percentile rank of scores. It's competitive. So as your peers all improve the quality of care delivery, that scale changes, and distribution of scores change. And as you remember from one of the previous discussions in this session, your performance against the percentage of your patients in hemoglobin A1C, that definition of poor control is never going to change, or it changes slowly. It changes only as the standard setting organizations, based on new data, change those numbers. And what's considered high blood pressure control similarly, and depression screening is depression screening. Those change slowly with care standards, but that's until those standards change, that's always what we're going to measure in the measurement program. But where you compare to your peers in those measures is really going to depend on everybody's performance year after year. So you're going to have to improve your score as your peers can improve their scores to continue to continue to hit your quality standard for Medicare's ACO quality measurement. And to therefore, when you hit that standard, you collect all of your earned shared savings. Nothing if you have a poor score, and ameliorate losses if you have a shared loss. You don't share fully in that if you get a great quality score. Thanks, Jason.
So Jason's next question for you, Dr. Mingle. Do ACOs receive any incentives or rewards for showcasing improvement on these measures, or are they solely required to report on them?
Another great question with some similarities to what I've already said. You'll get some clues in what I'll say on this one, but I think there's an interesting shift in perspective in the way you've asked this question. There is that small built-in bonus each year for improving quality over the prior year. So yes, as you improve, you get that extra boost in your score. Once you are collecting all of your savings, all of your shared savings, an additional boost of your score won't allow you to collect more. There's still room for it to go up, but no more room for you to get more shared savings. And your collecting those shared savings depends entirely on the quality performance, including the bonus. And despite generating shared savings, if there is poor performance, you may collect only part or none of the generated savings. Now, since it is a competitive process, improvement in performance is required to reliably continue to share in shared savings. So there's that built-in requirement to show improvement. And performance is reported annually on Medicare's public care compare site. So your score is as an ACO is published on that care compare site, and I urge you to look at it. Go to care compare, put in your organization's name, and you can see what numbers were most recently reported for you. So again, so it includes a score, so you can see the improvement, but it's not set up to easily show year-to-year improvement. It doesn't flag on that page that this represents an improvement from last year, but anyone who wants to look more deeply into the past or track it over time themselves can see what happens. So it is ultimately visible if you know how to look for it. Thanks, Jason.
And one final question for you today from Jason. Lastly, is there any way to model or estimate how improving the health of patients across a panel might translate into increased shared savings for an ACO? Understanding the relationship between patient health outcomes and financial incentives could provide valuable insights into the ACO system's effectiveness.
Great question. Again, a little some overlaps between what I've answered already, but again, a nice unique perspective to this question, I think helps bring better understanding. Medicare's quality payment program, including its alternative payment models, one of which is Medicare's shared savings program, which is one of multiple possible varieties of an accountable care organization, they're all about paying for value, trying to get away from pure fee for service, which we've done for decades and decades, and start rewarding us for value. Now, value is quality divided by cost, so neither of them solely drives the reward in any of these programs, and the ACO program not the least. If it works, higher quality care brings higher payment. If it's working well and all the systems are aligned, all the factors we discussed earlier are aligned. Now, the primary driver of financial reward is shared savings. So have you saved money in your ACO year over year? And Medicare has standards for setting the benchmark year in cost, and then your current year's cost is compared to that. And if there's savings, if you spent less than they expected you to spend, that's your shared savings, and your contract with Medicare is going to reflect what percentage of that you stand to gain. Medicare gets some benefit, you get some benefit. So the maximum value of that payment is set by your cost performance, but they don't want you to just simply save money by giving slipshod care. You have to prove some basic level of quality performance to collect any of those savings. Now, getting to that benchmark, that quality standard, as you go above that, you don't get more payment. That's limited by how much you actually generated in your cost savings providing the care. So your quality performance is necessary to collect the shared savings that you generated. Now, it may very well be that the expense of your care actually went up, and that certainly happens across the population of ACOs. And then if you're in an advanced APM, advanced ACO, and you have qualified providers in that ACO, you are subject to losing money if your care is higher than predicted. And quality performance, again, can ameliorate that, but not erase it completely. And low quality, if you fall below the quality standard, you will be subject to your full shared losses. So again, quality is a factor, but it's not purely related. You don't get direct reward from continued increase in your quality above that quality standard in your operations. Thanks, Jason. Another great question. I hope I've helped add some clarity to all that and not just confuse it more. So ask it in another way if I can help.
Yeah, thank you, Jason, for the excellent questions, and thank you, Dr. Mingle, for sharing your insight with us today.
Thanks, Jason, for all the great questions. Thanks, Kyle, for participating in this. I want to be helpful, and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.